Let's be honest, the US healthcare system is on a collision course with economic reality. Today, we're going to look at the blueprints for a pretty radical redesign, one that promises better care at a lower cost. So let's dive into the architecture of value.
Okay, so let's just get right to it. Here's the big question that's going to guide our entire discussion. Is the US healthcare system, is it actually on a sustainable path? It's a really simple question, but believe me, the answer is incredibly complex and super urgent. And, the numbers, they really paint a stark picture. By 2033, healthcare is projected to eat up over 20% of the entire US economy. To put that in perspective, that's more than the whole manufacturing sector. After a decade of things being relatively stable, this is basically a five-alarm fire for the economy. So what's fueling all this? Well, it's a massive demographic tidal wave. The 65 and older population is growing by nearly 3% every single year, while, and get this, every other age group is actually shrinking. This isn't just some small shift, it's a fundamental reshaping of our society, and it has huge implications for healthcare. And here's what that aging population actually looks like in the real world. A staggering 93% of adults over 65 have at least one chronic condition, and almost 80% are juggling multiple. This is the new normal, folks, and it's what's driving up both the complexity and, you guessed it, the cost of care. Okay, so with a problem this big, where do you even start? Well, the good news is there are some really innovative models already out there working. Let's move to our first pathway and see how this builds out. A fundamental redesign that starts by simply shifting where care actually happens. The idea here is actually pretty simple, but it's incredibly powerful. It's all about taking procedures that don't absolutely need to be in a super high-cost hospital, think elective surgeries, and moving them to more efficient, less expensive settings, like specialized surgery centers, or even, in some cases, right into the patient's home. And look, this isn't just a theory, it is happening at a massive scale right now. Just take total joint replacements, for example. In 2018, nearly 80% were done in a hospital. Fast forward to 2023, and that number had completely plummeted to just 9%. I mean, that is a revolutionary shift in just 5 years, and it's a total game changer for costs. So what does this mean for the bottom line? Well, here's the payoff. Because of that shift, the overall cost for a joint replacement actually dropped by 9%. But look closer at this. The cost for the procedures that stayed in the hospital, they actually skyrocketed by 38%. The entire savings came from moving that care to a more efficient place. Okay, but here's the million-dollar question, right? Are we just trading cost for quality? Is this safe? Well, the data is crystal clear. Absolutely not. In fact, quality got better. Complication rates actually went down in those lower-cost outpatient and ambulatory settings. This is the holy grail, right? Better outcomes at a lower cost. So shifting where care happens is a huge piece of the puzzle, but it's not the only piece. Let's move on to our next two pathways, which focus less on where care happens and a lot more on how that care is managed and, importantly, paid for. And we're seeing two dominant models emerge here. On one hand, you have the payer-led model. Think of this as a top-down approach where insurance companies use massive amounts of data to manage the system. Then, on the other hand, you have the PCP-led model. This is more of a bottom-up approach that puts primary care doctors in the driver's seat by giving them financial risk for their patients' health. You can almost think of the payer-led model as, well, it's like playing Moneyball with healthcare. They use big data to do it. By analyzing all this information, they can spot at-risk patients before they get seriously ill and streamline a lot of the administrative headaches. And the result? A pretty solid 2 to 3% in system-wide savings. All right, now let's flip the script and look at that PCP-led model. The idea of empowering doctors sounds great, right? It's incredibly appealing. But as this quote from the source material makes really clear, the reality on the ground has been tough. A lot of these provider groups have struggled financially, and the results have been, well, mixed. So you might be asking, if it's so tough, why is everyone still so invested in this model? It's because the potential upside is just enormous. When these primary care-led models actually work, they can slash the total cost of care by 6 to 10%. That's a game-changing level of savings, which is exactly why everyone is so focused on trying to crack the code. Okay, on to our fourth and final pathway. This one zooms in on some of the most complex and often the most expensive areas of medicine, specialty care.
The idea here is to take that value-based approach, which really just means getting the best possible health outcomes for the most efficient cost, and apply it to specialized fields. This is done by building these integrated teams of specialists who coordinate a patient's entire journey, all the way from diagnosis through treatment.
And when you look at the potential savings here, I mean, they're just staggering. We're talking up to 7% in orthopedics, a huge 17% in oncology, and a jaw-dropping 27% in kidney care. By focusing on these really high-cost specialties, you can make a massive dent in overall spending. And again, this isn't just a nice idea on paper. Check out the results for chronic kidney disease. Patients who were in a coordinated specialty program for 5 years saw their total healthcare costs fall by 14%. That's real proof that this model of sustained, expert-led management can deliver incredible results. So, let's recap. We've got these 4 really powerful blueprints: shifting care sites, managing risk from the top down and the bottom up, and bringing that value focus to specialty care. So, let's pull this all together now and look at what it's actually going to take to build this new system. But here's the thing, and this is maybe the most important takeaway. No single group can do this alone. It absolutely requires coordinated action across the entire board. Hospitals and providers, they need to keep moving procedures to more efficient settings. Primary care groups have to adopt the tech to make these risk-based models work. And the payers, they need to get smarter with their data and create the kinds of contracts that reward this high-value specialty care. And all of that brings us right here to our final thought. The models we've walked through today, they aren't fantasies. They are proven blueprints for a more affordable, a more effective, and a more sustainable healthcare system. The plans exist. The evidence is there. The only question left is, who's going to have the clarity, the coordination, and the commitment to actually build it?